Thank you, Ruchika. A very good morning, everyone. So after that wonderful session on the screening, now we move to another entity which is entirely different from that. But why it is important is because hypertensive disorders complicate 10% of the pregnancies, and in spite of all the advancement in the obstetric medicine, it is still one of the leading causes of maternal and fetal morbidity and mortality worldwide. If we diagnose it correctly in proper time, it is preventable up to a large extent. And when we diagnose it, we are also preventing the long-term implications of hypertension because it is associated with various long-term implications like cardiovascular complications, stroke, renal failure in the long term. And so we have this opportunity during pregnancy to intervene at an early stage and to halt the disease trajectory at the correct time. So hypertensive disorders of pregnancy, it can be gestational hypertension when hypertension is detected for the first time after 20 weeks of pregnancy with sustained BP elevation of more than 140 by 90 millimeter of mercury on more than one occasion, 4 to 6 hours apart. It can be preeclampsia when hypertension is associated with proteinuria. And we as obstetricians are dealing with these entities day in and day out, and we are all well versed with the management of these entities. But sometimes it can present as first time, it can be either present before pregnancy or it can present first time during pregnancy before 20 weeks of pregnancy, and cause may be entirely unrelated to pregnancy. Like preeclampsia and gestational hypertension is because of the placental malformation. When the cause is entirely different from pregnancy and it is either pre-existent or before 20 weeks, then it is chronic hypertension. And many times the patient come to us for the first time when they do not know that they have chronic hypertension, and obstetricians are the first one to encounter. And if we do not recognize it, if it goes unrecognized and misdiagnosed, it may lead to improper treatment and increased maternal and perinatal complications. So what are the complications it can lead? It can lead to cerebrovascular accidents, pulmonary edema, renal failure, cardiomyopathy, stroke, superimposed preeclampsia, abruption, hemorrhage, preterm delivery, low birth weight, and can lead to perinatal death. So we need to identify this entity. So most of the time, in 90% of the cases, chronic hypertension is essential. But in certain cases, and up to 10% of the cases, it may be secondary to the underlying cause, which may be renal, endocrine, immunological, or vascular. And the common ones being the chronic kidney disease. It may be because of SLE, Takayasu and it is very important to identify the underlying cause to have a good maternal fetal outcome. So when do we suspect it to be because of an underlying cause? Should we investigate in all the cases? Should we suspect and investigate all the cases of chronic hypertension in order to search for the cause? Probably no, because in only 10% of the cases, it is associated with an underlying cause, and it will not be cost effective to screen all the women for the causes of secondary hypertension. So when should we screen for the causes of secondary hypertension? If hypertension presents at a young age with no family history, if there is presence of resistant hypertension, that is, even if we are giving the maximum dose of 2 to 3 drugs and the BP is not getting controlled, or if there are specific clinical features pointing to a certain diagnosis, like there are certain clinical signs and symptoms which point to the clinical diagnosis. So if they are there, then we investigate on those lines. So now I will be presenting a few cases in which we investigated and we found causes of secondary hypertension, and then we treated on those lines and had a very good outcome. So our first case will be presented by Dr. Khushbu. So Dr. Khushbu, please.
Thank you, ma'am. A very good morning to all of you. Now I'd like to present my case. She was Mrs. K, 24-year-old, second gravida, previous one preterm delivery, which was a loss actually. She was a known hypertensive for 1 year with the chief complaints of amenorrhea for 5 months. She was referred at 22 weeks for uncontrolled BP records from a heart care center. Obstetric history. She was married for 5 years. Her first conception was spontaneous in 2021. She was the pregnancy was supervised, and she was diagnosed hypertensive at 8 weeks. Her blood pressure was uncontrolled on maximum dose of levetiracetam and nifedipine, and subsequently there was an abruption at 32 weeks that led to preterm intrauterine death, and followed by a delivery, 850 grams stillborn female with no history of blood transfusion. Postpartum, she was started on angiotensin receptor blockers, beta blockers, and calcium channel blockers, and was managed by a cardiologist. Afterwards, after like 4 months, she again conceived. It was a spontaneous conception, supervised, chronic hypertensive, managed by a cardiologist. The drugs changed from angiotensin receptor blockers to levetiracetam and nifedipine, but the blood pressure was still uncontrolled. So she was referred to our OPD at 22 weeks. She had no family history of young onset hypertension, any cardiovascular accident, or a sudden death. On examination, her BMI was 90, so 22 beats per minute, and blood pressure was 156 by 90 millimeters of mercury. She had mild pallor. There was no neck mass, mucosal neck spots, no neck or abdominal bruise. Her cardiovascular and respiratory examination was normal. At abdomen, the uterus was corresponding to 22 weeks, and the fetal heart rate was 148 beats per minute regular. So provisional diagnosis was made. She was second gravida with one preterm loss, 22 weeks, chronic hypertensive on antihypertensives with history of severe preeclampsia with abruption with IUD in previous pregnancy with uncontrolled BP records. So she was admitted for further evaluation. On investigation, she was detected anemic. Her HB was 9.2. The general blood picture was microcytic hypochromic, and she had an iron deficiency anemia. The spot protein by creatinine ratio was normal, and rest of the investigations were normal. She was diagnosed hypothyroid and started on 50 microgram thyroxine, and OGTT was done, and she was diagnosed type 2 diabetes mellitus, and she was started on medical nutrition therapy and split insulin. For our iron deficiency anemia, the deficit was calculated and injectable iron was started. On fundus examination, she had grade 3 hypertensive retinopathy. On 2D echo, she had mild concentric left ventricular hypertrophy with grade 1 left ventricular diastolic dysfunction. Her ultrasound, KUB, and renal Doppler was normal. During the hospital course, the dose of antihypertensives were increased further to levetiracetam 300 mg 4 times a day, nifedipine 20 mg 3 times a day, and clonidine was also added 0.1 mg twice a day. There were multiple episodes of headache, palpitation, hypertension, followed by hypotension, which was a labile hypertension present during hospital stay. In view of high index of suspicion, she was investigated further with an MRI. MRI abdomen showed a P2 hyperintense mass of 3.4 by 2.2 centimeter in the right adrenal and 6.7 by 5.7 centimeter in the left adrenal area, suggestive of the Pheochromocytoma. Urine metanephritis was done, it was normal, and non-metanephritis were reduced. So final diagnosis was made. She is second gravida, paragraph 28 weeks, chronic hypertensive, non-case of Pheochromocytoma, hypothyroid, type 2 diabetes mellitus, on insulin, with history of severe preeclampsia with abruption with IUD in previous pregnancy with fluctuating BP records. So she was further managed by a multidisciplinary team consisting of neonatologist, endomedicine, endosurgery, obstetrician, and anesthetist. Alpha blockade was started. Taprazone with a starting dose of 15 mg, and which was further titrated to 25 mg per week for a total period of 20 days. She was monitored for superimposed preeclampsia, and regular fetal growth monitoring and ultrasound was done. During even after alpha blockade, her BP records were fluctuating, and she had hypertension. Her BP record was uncontrollable. So elective cesarean was done at 34 weeks after appropriate alpha blockade. She delivered a young child, 2.2 kg, appropriate for gestational age, tried immediately, and Apgar was 7-8. The intra and the post-op blood pressure fluctuations was managed by MTG and other vasopressors. Post-operatively, antihypertensives were titrated to lower dose, and she was discharged on day 6 on alpha blockade. Subsequently, a laparoscopic bilateral adrenalectomy was performed after 8 weeks. The mother and baby the mother was not on any antihypertensives. So the learning from this case is we have to have a high index of suspicion for uncontrolled BP records with fluctuating labile hypertension. Any antihypertensives also can interfere with interpretation of urinary metanephrines like clonidine and mebutanol. So the metanephrines were normal in our case. And then remains mainstay for diagnosis. Ultrasound may miss the diagnosis because an ultrasound KUB was normal. The definitive treatment is cesarean section followed by adrenalectomy, which is a preferred approach if a bilateral pheochromocytoma is diagnosed in late second trimester. So a few lines about pheochromocytoma in pregnancy. Hypertension, as already explained by ma'am, hypertension affects 11% of pregnancies in India. Pheochromocytoma is extremely rare. The incidence rate is 0.07%. Undiagnosed, the maternal and fetal mortality approaches 50%, but if diagnosed and treated timely, mortality rate decreases drastically. The biochemical and the imaging say as a non-pregnant, raised plasma on 24-hour urine metanephrine and non-metanephrine concentrations. For imaging, ultrasound and MRI can be used to localize the tumor. The diagnostic sensitivity of MRI is 90 to 100%. The management, the medical management is basically hypertensive management. The hypertension management, it should be started with alpha blockade. It works by alpha adrenergic receptor block. Blocking the alpha adrenergic receptors, it prevents the catecholamine-induced serious complications during pregnancy. And we can add a beta blocker if there is tachycardia. The definitive treatment, however, is surgical resection of tumor. Optimal timing is late first or early second trimester. When diagnosed in late second or third trimester, cesarean section followed by tumor resection is done. If diagnosed early, a laparoscopic adrenalectomy can be done in second trimester. So the take-home message is it is a rare entity with a very high maternal and fetal mortality rate. So high index of suspicion for women for presenting with refractory and fluctuating hypertension. MRI remains mainstay of diagnosis. The treatment should be in a specialized tertiary care center, and timing of the surgery depends on the time of presentation. Now, I would like to invite my colleague, Dr. Namita Shrivastava, for the second case presentation.
Thank you. A very good morning to our respected teachers and all my dear friends. Please. Mrs. J, 32 years primary gravida, referred to MRH at 31 weeks 3 days gestation with chronic hypertension and fetal growth restriction. The patient presented to us with the chief complaints of swelling of the bilateral limbs and abdominal wall, uncontrolled chronic hypertension, and moderate anemia. She had an USG done at private clinic at 28 weeks, 3 days gestation, suggestive of fetal growth restriction with raised resistance in the umbilical artery. Now, coming on to obstetric history, patient was primary gravida. She had a spontaneous conception, which was supervised. She was diagnosed as hypothyroidism and chronic hypertension in the first trimester and was started on tablet thyroxine 50 microgram, tablet ecospin 150 milligram HS, and tablet labetalol 100 milligram TDS. Anemia was diagnosed in the second trimester, but it was not improved on tablet iron twice daily. He also received injection iron sucrose 500 milligram at 28 weeks of gestation. On examination, at 31 weeks, 3 days of gestation, she had a pulse rate of 104, which was hyperdynamic. She had a blood pressure of 150/90 mmHg of mercury. Respiratory rate was 18 per minute. Pallor was there, 2+, and clubbing ictus absent. Bilateral pedal edema and abdominal edema was present. On abdominal examination, she had a symphysis fundal height of 28 centimeter, breech presentation, and having a regular fetal heart of 130 beats per minute. Cardiovascular, respiratory, and central nervous system were normal. Breast and thyroid normal. On investigation done at our center, hemoglobin was 7.8 milligram per deciliter, mean corpuscular volume was 110.3. She had a platelet count of 1.4 lakhs per mmQ, and the iron saturation was 30.6. Serum ferritin was 407.7, suggestive of anemia of chronic disease. Serum creatinine was 2.7 milligram per cent, and she had an urine 24-hour urinary protein 1400 milligram per day with a spot PC ratio of 2.27. Her oral glucose tolerance test was normal. Ultrasound done at USG at MRH at 31 weeks, 3 days gestation, suggestive of single intrauterine fetus, 28 weeks, 3 days, 6 days, breech, placenta was posterior, and estimated fetal weight was 1.6 kg, 1.06 kg. AFI was 10.6 centimeter. On Doppler, umbilical artery pulsatility index was 1.32, which was 85th percentile according to the gestational age. Cerebral placental ratio was less than 1. Ductus venosus was normal. In the fetus, dilated transverse colon was seen. On maternal ultrasound, renal USG done, which was suggestive of bilateral echogenic kidney, in which poor corticomedullary differentiation was there. Renal artery Doppler was done, and that was normal. On tendons examination, she had a grade 1 retinopathy, but barely detectable arterial narrowing seen. So the patient was referred to us with the provisional diagnosis of chronic hypertension and fetal growth restriction. After detailed clinical examination, history taking, and investigations, the provisional diagnosis was modified to chronic hypertension due to renal disease with superimposed preeclampsia, with anemia, which was megaloblastic, with fetal growth restriction, with raised umbilical artery resistance. Maternal and fetal prognosis was explained to attendants, and then the patient was admitted. After admission, patient venous blood gas analysis done, in which pH was 7.297, bicarbonate was 11.7, and base excess was -12, which was suggestive of metabolic acidosis. Correction done with injection sodium bicarbonate 50 ml IV 6 hourly, and it was given for 4 days. Renal diet started 4 hour blood pressure monitoring, then strict input-output charting done, and input was restricted to output plus 400 ml. Tablet labetalol dose escalated to 200 milligram per TDS according to the blood pressure. Renal function test, serum electrolytes, and venous blood gas analysis done on daily basis. The fetus was covered with dexamethasone, and anemia of chronic disease was treated with injection erythropoietin 4,000 units subcutaneously, and along with patient was transfused with 1 unit of red blood cells. Daily fetal monitoring and anesthesia continued. On the day 5th of the admission, that is on the 32 weeks, 3 days gestation, patient had an absent diastolic flow in the umbilical artery, for which she was taken for emergency LACS. She had a female child of 1.12 kg weight and abdominal 6 to 7. Post LACS, blood pressure was controlled with injection Lasix, BD, and tablet amlodipine 10 mg BD, tablet sodium bicarbonate 500 mg TDS continued. Patient was discharged on post LACS day 6 with baby in NICU, and on discharge, serum creatinine was 3.4. Venous blood gas analysis was normal. Patient is at present under the regular follow-up of the nephrology department, and she has developed end-stage renal disease by the 5 months after delivery. Her serum creatinine is 4.5 at present, and at present she is not dialysis dependent. Baby was discharged on day 59 from the NICU, and baby is doing well. Now, from this case, we have a learning that any hypertension known to be present before conception or first recognized before 20 weeks of gestation is defined as chronic hypertension. And the causes of chronic hypertension can be renal vascular disease, whose example is renal artery stenosis, chronic kidney disease, Takayasu arthritis, coarctation of aorta, Pheochromocytoma, primary aldosteronism, Cushing syndrome, primary hyperparathyroidism, and essential hypertension. Detailed history. For ruling out the cause of the secondary causes of chronic hypertension, detailed history, body mass index should be calculated, drug history is to be taken, blood pressure measurement should be done at every visit, and investigations should be done, which includes complete blood count, liver function test, renal function test, serum electrolytes, including calcium, serum TSH, urine analysis. Renal ultrasound and Doppler should also be done in these patients. If the patient is having any fluctuating hypertension or a triad of headache, usually found in palpitation and sweating, then the urinary metanaptines and MRH service is to be done. When none of the causes identified, then only the patient is considered to have an essential or an idiopathic hypertension. Chronic kidney disease is classified under 5 stages, and the perinatal complications such as peritoneal labor, preeclampsia, fetal growth restriction are all increased for all stages of chronic kidney disease. Now, coming on to take-home message, always thoroughly examine and investigate all cases of chronic hypertension to rule out the secondary causes. As in our case, the patient was having chronic hypertension due to chronic kidney disease. Measures should be taken to correct renal function, metabolic acidosis, correction of anemia was done, steroid coverage was done, and then adequate fetal maternal surveillance was done. Women with chronic kidney disease, they are at increased risk of preeclampsia, fetal growth restriction, preterm delivery, and cesarean section. Also, these patients, 50% of these patients have a risk of developing poor renal impairment, decreased GFR in the immediate postpartum stage only, and 20% of these develop to end-stage renal disease. So, risk of this permanent deterioration of renal function depends upon the presence and the severity of the renal impairment, hypertension, and proteinuria. Now, I welcome my colleague Dr. Namita Dore to present the third case. Thank you, Dr. Namita Shrivastava. I'm going to present my case, pregnancy with chronic hypertension with pulse not palpable. Mrs. White, 32-year-old female, Delta 2 para 0010 with known case of Takayasu arthritis, referred to MRH OPD at 5 weeks 4 days from immunology department for further evaluation, with chief complaint of amenorrhea of 5 weeks. Obstetric, Delta 1 spontaneous conception with medical termination was adopted. Delta 2 spontaneous conception referred from immunology department at SGPGI with UPT positive status. Patient on medication, tap prednisolone 5 mg and tap azathioprine 150 mg. On examination, pulse, radial pulse over palpable but visible. Blood pressure on right upper limb 110 by 70 mm of Hg, right lower limb 130 by 96 mm of Hg, right upper limb 98 by 70 mm of Hg, and left lower BP was 144/92 mm of Hg. Color was absent, abdomen soft, and CVS and CNS examination were normal, not within normal limit. My case, patient on first antenatal visit, prednisolone and azathioprine were continued. Half ecosprin 150 mg AD was started, and type labetalol was also started. Investigation: patient had pre-pregnancy CT angiography, which was suggestive of diffuse wall thickening circumferentially involving arch of aorta, brachiocephalic trunk, right common carotid artery, narrowing of the right subclavian artery, and origin of left subclavian artery. Hemoglobin was 12.9 grams per deciliter, TLC was 9,750, platelet count was 1,84,000. Investigations were creatinine 0.8, SGO2, SGPT were 2739, spot PC ratio was 0.12, ESR was 35 mm/half, CRP 3.4, urine microscopy suggestive of albuminuria. 2D echo was within normal limit. On fundus examination was also normal. ANA, DSDNA, and ENA are negative. Data scan was done, suggestive of twin chorionic intrauterine gestation. Patient was counseled regarding the risk to the mother in case of multi-fetal gestation with arthritis. Patient opted for fetal reduction done at 12 weeks, 2 days. Antenatal course, PFA scan suggestive of urinary tract dilatation of 2. Counseling was done. Patient refused for any further testing. OGTT was done at 22 weeks, which was genuine, started on medical nutrition therapy. UTI was diagnosed as 26 weeks, treated with oral antibiotics. Diagnosed with intrahepatic cholestasis of pregnancy at 36 weeks, started on RC-deoxycholic acid, 300 mg TDS. Patient was admitted at 36 weeks, 1 day. Growth scan was done, which was suggestive of oligomelas. Ecosprin was stopped. Admitted for maternal and fetal monitoring. Blood sugar profile normal on medical nutrition therapy. Blood pressure was also controlled on labetalol. Hospital course, bi-weekly NST and physical profile was done. Induction of liver done at 37 weeks in view of ISCP with chronic hypertension. Emergency LSCS was done in view of failed induction. Baby weight 2.7 kg, appropriate for gestational age with gas 789. Hospital post, baby on mother side since day 1. Patient and baby discharged on post of day 6. Pregnancy with Takayasu arthritis. Rare chronic Takayasu arthritis is a rare chronic inflammatory disease. Systemic vasculitis with resulting stenosis affecting the aorta and its branches. Female of reproductive age group suspected if hypertension with asymmetrical or pulse absent and if discrepancy in blood pressure in 2 arms. Diagnosis is based on combination of clinical history, physical examination, and vascular imaging, CT and MRH golden standard. In pregnancy with there is increased risk of pregnancy complications like hypertension, preeclampsia, prematurity, and fetal growth restriction. Blood pressure control crucial throughout the pregnancy. Learning from the case, pregnancy is not contraindicated in case of Takayasu arthritis. Water. Steroid and azathioprine can be continued in pregnancy. Steroid predisposes to gestational diabetes. Examination of pulse is important. Peripheral blood pressure should be taken in both extremities if this is found. In pregnancy, further option from early can be given. Take-home message: preconceptional counseling, peripheral blood pressure monitoring in both extremities as may miss the worsening hypertension. Monitoring for worsening of hypertension and superimposed preeclampsia, multidisciplinary approach in tertiary care center for favorable outcome is must. Thank you. Invite Dr. Sangeeta ma'am to conclude the session. Thank you, Namita, for that. So, whenever we come across a case of chronic hypertension in pregnancy, we need to counsel her very well regarding the risk associated with the pregnancy and the maternal fetal outcome. We need to review her medications because we need to stop certain agents which she might be taking before pregnancy, like angiotensin ACE inhibitors and angiotensin receptor blockers, which can cause malformations as well as growth restriction. Then we need to do baseline investigations, which we have already discussed and we have done in these cases. And we need to see for end organ involvement like echography, ECG, because these patients may have dilated cardiomyopathy and deranged cardiac functions. Fundus need to be examined in order to rule out hypertensive changes in the retina. So then we need to start her on low-dose aspirin, preferably before 16 weeks of pregnancy until delivery, and all practice guidelines for women with chronic hypertension in pregnancy do recommend for that. We need to monitor for fetal growth by ultrasound, and patient is educated regarding the symptoms of severe preeclampsia because superimposed preeclampsia is common in these patients of chronic hypertension. Then how do we treat? That is the most important part because now we have worked her up, we know the diagnosis, she is chronic hypertensive. So how do we optimize her blood pressure? Because optimization of blood pressure is the key determinant in achieving the good maternal fetal outcome. So when should we treat? What is the threshold blood pressure levels for which antihypertensive medication is started? What are the treatment targets and how do we treat? So this is the summary of the published guidelines, and nearly all the guidelines recommend starting the treatment when the blood pressure is more than 140/90. But ACOG still recommends treatment when in severe hypertension only. So we try to find out that why treatment BP thresholds are higher in United States compared with the majority of international guidelines, which are addressing hypertensive disorders of pregnancy. So we looked into the literature, and what we found was that this was the first paper which was published in Lancet, and they reported that antihypertensive therapy is associated with increase in the risk of small for gestation newborn. Then there was this very famous trial, CHIPS trial, control of hypertension in pregnancy study, which was an international randomized control trial, including 987 women. And this included both the patients of chronic hypertension as well as gestational hypertension, but 75% of them were chronic hypertensive. And what they did was they compared the effect of tight control of blood pressure to less tight control on pregnancy outcomes. So they concluded that tight control of hypertension reduced the incidence of severe hypertension, but overall risk of SGA newborns and serious maternal complications did not differ between groups. Also, there was no reduction in perinatal morbidity and mortality. Then there came this Cochrane analysis, which was published in 2018, and they included 58 trials with 5,909 patients, and they reported that treatment of mild to moderate hypertension reduced the risk of severe hypertension, but there is little or no effect on the development of superimposed preeclampsia, fetal growth restriction, preterm birth, and perinatal outcome. So, because there is the decrease in the risk of severe hypertension almost twofold, that is why most of the international guidelines now recommend treatment when the BP is more than 140/90. But ACOG still recommends treatment when the blood pressure is more than 160/110 because they say that there is insufficient data of improved maternal and perinatal outcome with tight BP control. And also there are concerns of compromising uteroplacental blood flow with aggressive BP control. So now came the CHAP trial in 2022, that is chronic hypertension and pregnancy trial. This is a multi-center randomized control trial, including 2,408 patients. And what they reported was that active treatment is associated with reduction in severe hypertension, preeclampsia with severe features, preterm birth, and SGA, that is less than 10th percentile, did not differ significantly between the groups. So there was no incidence of SGA even with aggressive control of hypertension. So they concluded that treatment of mild chronic hypertension in pregnancy to a target BP of less than 140/90 improves maternal and perinatal outcome without negatively impacting the fetal growth. And with the result of this, after the result of this trial, Society of Maternal Fetal Medicine now recommends treatment with antihypertensive therapy for mild chronic hypertension in pregnancy to avoid BP of less than 140/90 millimeter mercury. So practically all international guidelines now recommend treatment when the BP is more than 140/90. ACOG guidelines have not yet been updated after this trial. After 2019, it has not been updated. So how do we treat antihypertensive therapy? We all know this. The drug of choice are labetalol, nifedipine, and methyldopa, with the first choice being labetalol. Not going into the details because we all are practicing this day in and out. Labetalol starting dose is 100 milligram TDs to QID, going up to 300 milligram TDs to QID. Maximum dose is 1200 per day. For nifedipine, the starting is 10 milligram BD to TDS and maximum dose is 120 milligram per day. And for methyldopa, we all know this. So now into the details. The antihypertensive therapy for severe hypertension, we need to give IV labetalol, either bolus or infusion. Bolus is 10 to 20 milligram repeated in the double dose to 20 to 40 and then 40 to 50 going up to a maximum of 300 milligram, or we can give a continuous IV infusion of 0.52 milligram per minute. Nifedipine, if we are giving, then we need to give 10 milligram and then we need to repeat it after half an hour 10 milligram, and then further doses are to be given as per the blood pressure, or we can give an IV hydrolazine 5 milligram up to a maximum dose of 20 milligram. So now which drug to be given? That internationally all the guidelines say that which drug is to be given, right? Like no study has proved the benefit of one drug or the other, and it is up to the treating physician and the local guidelines. Whatever they suggest, any drug can be used for the treatment of severe hypertension. So when should we deliver these patients? Again, it has to be individualized. If the chronic hypertension is associated with no maternal and fetal complications, like the Dopplers are normal, growth is normal, doctor is fine, then we can take her up to 38 weeks. And some guidelines even say that we might take her up to 39 weeks also. But if it is associated with superimposed preeclampsia, then if it is without severe features, we need to deliver her at, I'm so sorry. I'm really sorry for that. Without severe features, 37 weeks, and with severe features, she should be delivered by 34 weeks. Sorry for that. So to conclude, timely diagnosis and management leads to excellent pregnancy outcome in chronic hypertension in pregnancy. It is important to look into the causes and do individualized management for the best outcome. A thorough history, physical examination, and relevant investigations is the key to detect rare causes of secondary hypertension. And then we, as an obstetrician, we have this unique opportunity to do lifestyle interventions at an appropriate age, because the patient presents to us at appropriate time when they are in their 20s and 30s, so that we can prevent long-term morbidity in these patients. Thank you so much for the patient hearing. And